Thank you very much. What I'm going to try and do really is to draw some of these threads together. We've had a very rich morning of presentations, and what I want to do is to set them in context and to say a little bit about how they fit in with some of the broader discussions going on at the global level. Well, of course, universal health coverage is very much on the health community's mind at the moment. Between 2005 and 2012, essentially all nations have made the commitment to achieve universal health coverage, which can be defined as on this slide, with a particular emphasis really on avoiding the risk of financial ruin or impoverishment from accessing effective health services. So we've seen quite a major political transformation around universal health coverage. And of course, as we know, financial risk protection is quite patchy, and this slide just shows you where the main problems are. According to WHO, around 150 million people suffer catastrophic expenditure as a result of major health problems each year. So it drives a lot of people into poverty, including some people who are not necessarily close to the poverty line. And of course, this has a major impact on development. But it's also true to say, of course, coverage of health services is uneven. Everyone knows that, of course, there's a differential between wealth, and this slide just shows you the relationship of coverage of maternal and child health services from the poorest to the richest wealth quintiles. But the thing that's really striking here is a variation within the quintiles. So what it shows you is that some countries do remarkably well at covering their poorest quintiles. And so we need to understand better why it is that some countries with relatively limited resources can achieve much higher levels of equity than others. And I think that's a key issue for research and also for policy. And I think we've heard some of the success stories here this morning. Well, what does universal health coverage imply? There's basically sort of three dimensions of universal health coverage. One is extending the current level of coverage to the non-covered, so ensuring that the whole community is covered, the whole population. And that may include in many countries ethnic or religious groups that are marginalized. Then there's about the other dimension is about reducing cost sharing and fees. And it's been very heartening to see how the whole user fee debate has moved on, and there's a general consensus, except apparently among some members of our own government, that user fees are a bad thing and should be avoided. And then we see the importance of increasing the delivery of different services. And this is a particular challenge because, of course, many countries are being hit by the double burden of heavy burdens of malnutrition, of infectious diseases, together with the growing burden of non-communicable diseases. So this is going to be a growing challenge in the years to come. But the evidence base is moving on, and there's a growing body of rigorous evidence in the area. There's an excellent article by Moreno, Serra and colleagues in The Lancet a couple of years back. And to summarize the evidence, it shows that broader health coverage, both access and financial protection through pooled spending mechanisms, does result in health gains. These tend to be larger in poorer countries and for poorer groups. So there's clearly some generalizable lessons there, but nevertheless there are institutional factors that modulate whether these strategies are successful in different countries, different settings. The other point is the importance of new knowledge. I think this has been highlighted by the World Health Report last year on research for universal health coverage. And what the message that it's giving really is that biomedical research, of course, is important, it's necessary, but it's not sufficient. So you also need other types of research as well. We need health policy and systems research, public health research around the social and environmental determinants of health. So it's important to cover the whole spectrum of health research if we're really to advance the agenda of universal health coverage. And it's also important to do locally relevant research and to build health research capacity in low-income countries. This is just one example taken from the World Health Report of emergency obstetric care in Burundi. And what it shows you, very briefly, is a country with a very high maternal mortality ratio. And what they did was to develop an emergency obstetric care facility, including ambulance transfer with a local telephone exchange and operator. And what it shows really is that in 2011 they were able to bring down the maternal mortality ratio in this particular district very, very dramatically and get below the MDG target. bringing them really to the levels that you see in many much more prosperous countries. So this just illustrates how local operational type research can be really quite transformative, and also emphasizes the importance of building research capacity in country. We've also seen a dramatic advance in the evidence base around community-based interventions. We've seen some of this reflected in some of the case studies, but there's also a growing burden of evidence. For example, this is from randomized trials of community health workers, various types of community health workers, on neonatal and perinatal mortality, showing really quite substantial reductions through a range of different types of community health workers. They have different names in different countries, different training and so on. But the message is fairly consistent. You can get substantial improvements in mortality in perinatal and stillbirth. What is important to say is that a lot of evidence now is growing, building up around the increased capacity and capabilities of primary health care workers, primary care teams, to deliver on priority health goals. And there's just a few key points summarized in this slide. One of them is the importance of community engagement and intersectoral action, which I think has come through quite consistently this morning. That's easy to say, but it's not so easy to do, but very important to keep moving on that agenda. There are also technologies that can support frontline health workers. Rapid diagnostic tests is an obvious example for malaria, syphilis, for example. Quality improvement, we're seeing a big expansion of the evidence base around quality improvement strategies. The work of Alex Rowe, for example, this tremendous systematic review he's been doing for many years, which hopefully will be in the public domain soon, around effective interventions to improve the quality of primary care in low-income settings. And new technologies like mHealth may also help. A lot of work around the home-based care for chronic diseases, showing that you can safely take that out of hospital and facility settings into the community with appropriate supervision. And evidence that we can also expand these kind of concepts into the NCD and mental health agenda, as outlined and articulated in series in the Lancet, showing that this can be done cost effectively through primary care and public health interventions. And then finally, the experience of scaling up at the national level. And the important message here is that this is often being driven by national governments. It's not necessarily being driven by donors. We've heard this morning about donor-driven activities, which are very important. But there's also a lot of activity being driven by national governments. And some of these are beacons for their regions. So, for example, Ethiopia. A lot of African governments now are looking to Ethiopia. They're sending their teams to Ethiopia to learn how the Ethiopians have scaled up their health extension worker program and their health development army. We see successes also in Pakistan. And Brazil is another good example of a middle-income country which has scaled up universal access to primary health care using a mixed primary health care and medical model very successfully. And Brazil is now becoming quite a major player in Africa through its links with Lusophone Africa. But of course there are still problems that are not fully addressed. One of them is the low-income countries under stress, or whatever you want to call them, fragile states have been given different names. They're home to half a billion people, and where many of the problems still exist. We've heard about some countries which might have been classified as LICUS countries or are emerging from that stage in their development. And I suppose the message from this morning is we shouldn't categorize countries as having no hope or not having the sufficient wherewithal to emerge from these difficult circumstances, because it's very clear that things can turn around quite quickly. So I think what we've heard this morning is a message of hope to say that, yes, it's possible to turn around some of the depredations of conflict, of poor governance and so on, really quite quickly with effective policies using evidence-based approaches. And so hopefully we can address some of these residual foci of high maternal mortality and so on. And then just in conclusion to say, well, how does this fit with the post-2015 agenda? This is an area of very, very active discussion and debate right now. Those of you who are following it will know that the Open Working Group has issued a paper in the last few days, which I have to say I haven't fully read, but it articulates 17 potential goals. Undoubtedly, many of these will fall as a result of political negotiations, but it's quite an ambitious agenda. This is the agenda outlined by a high-level panel of eminent persons. last year or so, which they came out with 12 illustrative goals, and others such as the UN Sustainable Development Solutions Network have come out with 10 goals. What's fairly consistent amongst all of them is that there's one key health goal, but there are many other goals that are related to health. So they're related to the determinants of health. So around nutrition, for example, and agriculture, gender equity, violence, food and agriculture, sustainable development more generally. And so I think we have to capitalize on the potential to influence many of these other goals. Obviously the health goal is very important. Universal health coverage, health systems are vital, but they're only one part of the agenda. We also have to complement that by looking at the social and environmental determinants of health and ensuring that the indicators and targets reflect aspects of sustainable development that are related directly to health. So for example, clean energy. I mean, we now know that household energy, 4 million people more, many of them women and children, are dying because they are exposed to very high levels of fine particulate air pollution in the home. And that can be addressed by clean cook stoves or by electrification. So that's just one example of a goal which is vital for health. We also, I think, need to look ahead to the challenges in the decades to come, and this slide just summarizes the effect of climate change on cereal grain yields. It's taken from a UNDP piece of work some years ago. And what it shows you that as you look ahead over the next few decades, there are some very significant challenges ahead. And I think here there's a kind of disconnect between the global health community, which is seeing everything improving more or less at fairly dramatic rates, but varying from one country to another. And then when you look at some of what's coming out of the climate change community, we're seeing some very significant challenges. And this slide just summarizes one of them, which will be on global food availability. Because although there may be some increased cereal grain yields in northern hemispheres, and even that's doubtful when you get to the second half of the century, in much of the world there are substantial decreases as shown by the red on this slide. And that's something we haven't fully come to grips with yet. And it's not really being factored in sufficiently to future plans. So we mustn't, I think, ignore this very significant challenge for the future. And when you look ahead towards the end of the century, we're now looking towards temperature rises of probably 4 degrees, sadly. That's global mean. And that will mean over land mass, perhaps 5 or 6 degrees. So imagine sub-Saharan Africa, maybe 5 or 6 degrees hotter. And what will that look like? And what are the challenges for health? So this is really, I think, a neglected area, and probably this kind of work is probably an underestimate of some of the challenges. So in conclusion, I would say there were two broad areas. There's universal health coverage, which has now got some political momentum, and hopefully can be achieved with political will and good governance. And obviously we need to generate new evidence to underpin and support that. And then there's the need to link health with the broader sustainable development agenda, and to bring in some of these big issues around environmental sustainability and social determinants. And to ensure that we disaggregate some of these SDGs so that, as Kevin said at the beginning, we can actually look at inequities in progress, because those have been bedeviled, I think, much of the progress we've seen so far. So I'll stop there. Thank you very much.
Andy, thank you so much.